Welcome to this exciting series of podcasts on diversity, equity, and inclusion under Radcliffe Cardiology. My name is Julia Grapsa, and I'm currently serving as a consultant cardiologist at Guy's and St. Thomas's. And I'm chairing the group of gender and equity under European Association of Cardiovascular Imaging. And I would like to welcome my partner in crime, Dr. Mirvat Alasnag, Director of Research and Catheterization Laboratory at the King Fahad Armed Forces Hospital in Jeddah in Saudi Arabia. And she has been, first of all, for me, a great mentor, a role model that I would look up. I'm looking up to. She has been the first female interventional cardiology in the Gulf region and has since represented women in multiple medical societies, including ACC Women in Cardiology International Working Group Chair and Women in Asia and Pacific Society of Interventional Cardiology Chair at the moment. And we are very honored to have our distinguished friend and guest, Professor Mamas Mamas, Professor of Cardiology in Keele University here in the United Kingdom, and is also an honorary Professor of Population and Health at the University of Manchester. Professor Mamas is an Associate Editor for Circulation Cardiovascular Interventions, and he's a member of ESC Cardio-Oncology Council under European Society of Cardiology, and also Senior Clinical Editor for TCTMD. So thank you, Mirvat, for doing this together. Thank you, Mamas, for being here today. And actually, I would like to start with the first question. Your paper under European Heart Journal that has a title, The Cutting Tall Poppies Down to Size, Lessons from the Tyrants of Ancient Rome. And I advise every young colleague or senior colleague to read this paper of yours because this is wonderful. And it's whenever I faced a difficulty, it was there for me to go and have a look and read it. And I felt more motivated. So, it's actually has to do with how many colleagues in the workplace, they have been through a difficult period in their lives. And this piece is very close to our heart for that reason. Practically, you write that tall poppies are denied opportunities within an institution, and there are people that will often disengage, and that the others that they will try and limit their successes or give others credit for the work, and they have led they have led some people in order to stand out less, and so minimize attempts to undermine them. They're often forced to choose between their well-being or success and face the inevitable consequences if they choose the latter. That's very impactful sentence. So starting from the first question, how you feel we could achieve equity and diversity in the workplace, and why we still see significant bullying and harassment?
So first and foremost, thank you for inviting me to contribute. I think this is a really important seminar series, and I can think of no better hosts than both yourself and Dr. Alasnag in leading this endeavour. I think first and foremost, we have to understand that this is a problem. I think many of us, particularly men that perhaps don't suffer as much as women, white men, think bullying, harassment is not a problem. But we see this in the workplace. So we've had multiple surveys from the ACC, surveys from the British Cardiac Society, European surveys, and they have all suggested that bullying, harassment, uncivil behaviour is commonplace. 30 to 40% of respondents will report having endured this behaviour at work. So I think that's the first thing, to recognise that it exists. I think the second thing to really think about is, why is it important that we have diversity and civil behaviour within a workplace? And again, there's lots of data around this showing that environments where you have bullying, harassment, lack of diversity, uncivil behaviour, it's associated with workforce unhappiness, high level of workplace absenteeism, poor quality of care delivery. So we know that a poor workplace leads to poor treatment and poor outcomes in our patients. I think third and foremost, now that we know that it's prevalent, now that we know that it has great impact, it's what do we do about this? And I think that's where really leadership of an institution comes in. And I think that's really quite important. We often choose our leaders in academic institutions or clinical institutions based on number of papers, based on grant income, based on procedural income or outward-facing attraction to bring business in. But actually, we don't really consider what I would say what is more important, which is defining the environment of the workplace. And perhaps we need to rethink our whole strategy around leadership. I think finally, when we're thinking around appraisals, we often think about, clinical excellence. We often think about income, publications, but we don't think about personal behaviours. We don't think about mentorship. And I think these are really quite important. If we as a community or as societies don't value these, then how can we change the workplace and the environment? We can't.
Mamas, you and Julia very elegantly described the problem, and you emphasized the role of institutions, particularly academic institutions and clinical institutions. But I want to take this a step further and discuss the role of large organizations and societies, such as the European Society of Cardiology, American College of Cardiology, in ensuring inclusion. So is it just a matter of checking a checkbox and making sure that you have equal representation of women or, ethnic diversity and minorities and so on? Or is there something else that we really need to be looking at a society level?
I think at a society level, societies haven't really gone enough. I mean, societies have been very much geared towards diversity and inclusion. I think in many ways there have been successes there. But that doesn't change the fact that in the workplace, there is still significant bullying, harassment, and incivility. So you can still have these things happen in workplaces that are diverse. And I think whilst everyone thinks, okay, 50% of a particular session or a particular committee are women, it's diverse, hey, job done, well done, guys. And that's really not the case. Because again, as we spoke earlier, I think it's a mistake to stop at diversity and inclusion. We need to think about civility and behaviours of individuals within a workplace. Very few societies have focused on this. I think the ACC has been one of very few societies that published their 2022 paper, which I would encourage everybody watching this webinar to read. I think it provides some very useful, actionable solutions. I think from a society perspective, what is the society's responsibility? Well, I think first and foremost, it's defining what the standards are. What are the standards of behaviour? What are the standards of expectations? I think there also has to be a code of conduct within a society. And failure to meet that code of conduct has to have implications. Again, it's not good enough to say, we encourage diversity. There has to be a code of conduct. There has to be standards. And again, very few societies actually have published standards of behaviour and civility. And there has to be adherence to those. And if there isn't adherence at a personal level, then there has to be consequences. That's number one. I think number two, the other important purpose of a society is education, providing educational resources. I think many of us don't realize that we have biases, biases that we don't recognize. I have biases that I don't recognize. All of us have biases that we don't recognize. So having the framework to be able to identify those biases, but also having educational programs to overcome those biases. I think, again, in terms of implementation in the workplace, again, providing guidance on how to do that. I mean, we often talk about, hiring more diversely, but it's not about putting a token woman on your interview panel. It's much more refined than that. And certainly from industry, industry has really led the way compared to many of our societies. So, for example, the Libra endeavour, which is a European Union-funded endeavour across 10 academic institutions that used many of the things that have been proven to be effective in industry from an academic perspective, and have given a very different framework around diversity and recruitment and what you require for that. And it's much more in depth than just saying, oh, well, you need a woman on the panel. And I think the other thing that I would say, again, is really important from a society perspective is that there's the carrot, or I don't really like carrots, but also the stick. And I think that's really quite important, in that a society has to have a means where there is a toxic workplace environment to have independent reporting, so to be able to find a framework through which members of the society can inform about toxic practices, toxic individuals that don't maintain the code of conduct as defined by the society, and perhaps also have the power for those failing institutions to request external reviews and really think about whether they recognize their program or remove recognition from programs, and programs that are unable to deliver a program which has civility, good behaviours, no bullying, no bias. So I think, the society has to take a much more greater leadership role. And I think societies have started to do that. But if we think about all, the councils, societies that we're part of, very few have a code of practice. Very few have standards that one should adhere to. And I think really that's the unmet need that a society really needs to think about.
Thank you so much. This is very interesting because, there, as I say, I started this podcast by saying that many of us, we've seen these examples in our workplace, academic environments, and I believe that we should be leading by example. Like if we speak up about against bullying and harassment, then our registrars, our trainees will do the same. Now, coming to this vulnerable group, which are the young colleagues, the trainees, I can see a lot of discouraged people around us. And this is because they feel that if they speak up and they explain their problems, they will be sidelined, they will be removed from their training, they will have problems with their training, consequences. So what advice you would give to institutions or organizations that they will keep the confidentiality of these complaints, how you would encourage actually the young people speaking up?
I think first and foremost, it's a great question. I think first and foremost, one has to be able to measure the size of the problem. If you don't capture this data, you don't know how commonplace and pervasive it is within your working place. Clearly, as you have said, many people don't feel the ability to highlight their experiences for fear of further harassment. And many people noticing these toxic behaviours remain as bystanders rather than upstanders. But most people will not challenge these toxic behaviours. And I think one of the problems is that academic institutions and also cardiology are very hierarchical, where the hierarchical relationships are developed based on dependency. And so, for senior leadership, often they're the people that bring in the big grants. And so often more junior faculty will often be dependent on financial support, or will be dependent on these individuals to get them on the podium. And so if they see toxic behaviours, they won't be an upstander, merely a bystander. And we see that all the time. There's a very famous North American institute, I'm not going to name names, where there is a real problem of bullying, and the DEI leads there will not, in private, they will talk about the harassment and bullying at the institution, but they will never be an upstander, because a lot of their income, their position on papers is dependent on the bully in this North American institution. We all know where this is, or many of us know. It's an open secret. I think we have to have clear mechanisms of reporting, first and foremost. So in the UK, we have in most hospitals or institutions the freedom to speak up guardian, where if you have bias or harassment or bullying, then there is a mechanism through which anonymously you can speak up to the individual. But then again, I think it's not just a question of capturing this information, it's then what happens. So if I make a complaint and say that, I'm being bullied, I'm being harassed, that there's microaggressions or uncivil behavior towards me, it's not a question of just capturing it, but then you need a whole framework through which to investigate it, to collect data, to put a plan, a plan for implementation, and then perhaps human resources. And let's not forget that from an institutional perspective, this is really quite important. And the reason it's important, it is a legal requirement. I mean, in the UK, we have the Equality Act, in which you cannot be harassed on the basis of protected characteristics, including sex, age, gender, religion, and so forth. And so, this is a legal requirement, both in Europe, both in North America, and both in the United Kingdom. And so an institution which allows such toxic behaviors to flourish opens itself up, number one, to reputational damage, but number two, also to legal challenges as well. So I think it's really quite important. I think often, though, it's very difficult for particularly younger fellows, but this could be senior people as well. Senior people get bullied and harassed as much as younger faculty, to have mechanisms for reporting outside of their institution. And that's where I think it's really important that a role that society could also contribute. Because if you're getting, reports of a faculty member of a society and their consistent reports about these toxic behaviors, then again, what the society has to be prepared to institute its code of conduct on the faculty individual, and perhaps, think about, disinviting them from meetings, not including them from meetings. If one is unable to follow simple civility and behavioral norms, and does not follow a code of conduct within a society, then they have no place in that society or on the podium for that matter.
Mamas, I want to shift gears slightly, but stay within the, diversity, inclusion, but also equity. And I think when we look at countries that maybe are still developing and so on, and how can we ensure that we're including them and offering them opportunities in the more global scientific stage? What advice and what steps do you see that we can do that?
I mean, I think it's a really good question. I think it's really important as well that we do so, because they bring a very different perspective, very different clinical experience than we would naturally have in Europe, North America. And I think the way that I tend to bring people on is to give them opportunities that they are left with a skill. I am not someone that believes that, giving someone a 5-minute talk on a podium or a webinar, I mean, at the end of 5 minutes, they don't have a skill left. They have an experience, and that's great, but there's nothing more to it than that. And so what I will do, for example, is have a research group. And so often I will try to get people involved in work, mentor them, get my statisticians to work alongside them. So they have a skill. They have a skill of being able to analyze a data set, write a paper. And so it's not something that will, last for 5 minutes with them, but rather it will be a skill that they have gained over a lifetime. That's where my area of expertise is. There'll be other individuals, other mentors, have other areas of expertise. And I know that both of you have done some remarkable things for fellows internationally. You, Mirvat, throughout the Middle East, you, Julia, as well, throughout Europe. I mean, it's fantastic to see. So I think it's providing a framework whereby you can put fellows from abroad in these areas that perhaps don't traditionally have representation on the global stage, and have a framework whereby they can be matched with key opinion leaders in areas of interest and focus to people that can help them. So, there's literally no point in someone who, say, is interested in echo and put them in touch with me. I can hardly read an echo. Whereas someone that wants to do research or research methodology or work with data, absolutely, I would be the right person for that. So it comes down to having societies say that, number one, this is important. That's the first thing. And number two, providing the framework by which interested individuals, and not everyone is interested, but interested individuals can be matched according to the skill set that they wish to gain. And to me, it's lifelong mentorship. So, for example, the people I've mentored, women from Syria. I've mentored men from Tajikistan. I've measured people from Croatia. And their requirements are very different. So for the girl from Syria, again, a very bright cardiologist, her requirement was understanding research methodology. She published many papers with me. I've tried to put her in touch with large research groups in the US so she can move over there. Whereas, say, for my Croatian colleague, I supported his application to EAPCI to get structural heart experience in the UK, who came and did a year of TAVI training with us. Whereas my Kazakhstani colleague, it was purely academic mentorship. He wanted an academic supervisor for a PhD. I worked with him for 3 years, providing mentorship and supervision. And I'm glad to say that he achieved his PhD a few months ago as a remote supervisor, and never having met him face to face. So I think there's many things that we can do. It just requires an open mind and perhaps some facilitation from the industry, from the society perspective.
That's really inspiring, Mama Sin. We thank you because that's why we consider you a role model and a great mentor, because you inspire people. Now, I want to take you to start with the British trainees. They published a statement last week, and while we were preparing this conversation, I thought that I want to ask about this. They described that their training is rather long and exhaustive, now adding general medicine into cardiology training, and to project this in a general aspect for every trainee, that we are requesting to do more and more and more, and then to do the training, and then another fellowship, and then another certification, and then subspecialization. So how much we exhaust young people, how much we are in danger of making them feel discouraged rather than encouraged, and how we push them to change potential trajectory.
I think what one has to separate is the issue of training versus the time working, and they're two very different things. In the UK, our so-called training is many years, but only a small proportion of that is actual training. A lot of it is service provision. And so I'm not sure that making cardiology trainees do a period of general medicine is particularly useful for a training perspective. I think it's purely to prop up the failing UK NHS system. I think, and again, this is not, I think we should maybe extend the focus from beyond the UK and talk about more global challenges. And I think, I think people equate time spent in a program with training, and I would argue that that's not the case. You can have high quality training in much shorter periods of time, and the programs that have very long so-called training, it's not really training, it's purely delivery of service. I think burnout is a real problem. And again, I want to sort of maybe pivot the conversation slightly in that we often talk about trainees, but what we don't talk about, I think, is a bigger problem, or as big a problem, is more middle grade and senior people as well. I mean, I'm on very many committees. I talk to people, and I know that many of my female friends have suffered all sorts of harassment, burnout, bullying in their workplace, and these are really quite established women that are known internationally in the field. So I don't think this is purely, and many of them are facing severe risk of burnout. So this is not an issue purely at the trainee level, but it's an issue that affects all of us. And when we talk about training, again, cardiology and medicine is lifelong training, and so things that impact on trainees will impact on us. And so, for a trainee, if the trainee decides he or she wants to learn TAVR, well, that's great. You go and do a fellowship in an institution and learn TAVR. Whereas for, say, a middle grade individual, what do? I mean, you're established. You may be a mother. You may be a wife. You may have difficulty in moving in a particular area. And I would say that then the middle grade individual is much more susceptible to local politics, to harassment, to bullying. Often, for example, if there's a new technology and there's training, often, the more accomplished women in the department will be passed over, and the training opportunity will be given to a younger man because of the issues of toxic workplaces, patriarchy, and so forth. So I think, in summary, we have to separate training from working, and I think this applies much more so to established women than trainees, because trainees you can just move. You can't do so as someone who's established in middle grade. And I think that's an area that we as a community haven't focused on. And I think, whilst trainees are important, let's not forget your more established colleagues, because that's where the bigger problem is.
Mamas, along those same lines, we often talk about research and principal investigators. And, it is real. We've seen the statistics. They've been published on and on. Few women are given the opportunity to become principal investigators in large trials. What do you think we can do to change that, to give them equal opportunity? I'm not saying to give them advantage, but equal opportunity to become PIs of large trials that impact practice.
So the first thing is to say, well, okay, why do we need diversity in clinical trial leadership? Why shouldn't we just stick with, white men with grey hair like myself? Surely we can give great leadership. That's the first thing. And I would say that the reason that we shouldn't stick with white guys with grey hair like myself is that there's a lot of work, academic work, that has shown that your trial recruitment is much more likely to be diverse if your leadership is diverse. I mean, this is scientific fact. You may say, well, okay, why do I want trial diversity? Surely if we just get a bunch of old men, it'll be great trial anyway. And again, that's not the way to think about it, because clearly when you're treating a diverse population, your trial has to reflect that population. And also, throughout medicine, we do see treatment efficacy having interactions by sex, by race. And so I think from a scientific perspective and from a clinical care perspective, it's fundamental to have a diverse group leading a trial. And many of the funders now will mandate that their trials that they're funding are representative. So to have 99% recruitment of men is simply not good enough for a publicly funded trial. It's completely inappropriate. The next thing is to say, well, okay, how do we ensure trial leadership diversity? I think first and foremost, it is opportunity in access to training. I mean, no one's born with knowledge of how to run a trial. There are lots of, like the Oxford trial course. I mean, there's lots of courses, there's meetings that are run. So I think having accessibility to that and ensuring that those that get to those meetings are diverse and not just a particular group of individuals from a particular region, but having a more global thought. I think secondly is the presence of people that have walked the walk. And so we're increasingly seeing many women now lead trials. So I think having people like that visible, people like Roxana, Harriet Van Spoor, Aleid Kiefo, Pam Douglas, these are people that have led trials, very visible individuals. And I think, that's important. But I also think that many of the trials are industry-led. I mean, who gets on the steering committee is often nothing to do with ability. It's to do with, who industry has suggested. And I think industry has a very important role to play here. And to think about, okay, who have we approached to lead this trial? Why have we approached them? Is it because they've just happened to have led every other trial? Who's on the steering committee? Is this based on expertise? And think about transparency. And again, this goes back to both societies as well as choice of leadership. Often people are appointed, that's how things used to happen in the Senate 2000 years ago in the Roman Empire. And we haven't really moved on from there, from these non-transparent means. I think, we and often, if someone says to me, who should we have for X, Y, Z? I think of my friends. I think, oh yeah, she'd be really good. She'd be really good. Is that the right way to do it? No. I think there has to be a formal application process whereby, people put their experience, their expertise, and then there should be some sort of independent committee choosing individuals on the basis of fit, appropriateness, and ability to lead the trial, rather than just being lazy and just choosing the same 5 men that always seem to be running the same trials, and some specialities much so, more so than the others. I mean, just look at, I guess, things like some of the heart failure trials. It's the same 5 dudes running all the trials. I think we need to move on now.
Well, Mamas, it's been a pleasure talking to you. Thank you and Julia. I don't think there's a rock we haven't turned when we're talking about diversity, inclusion, and equity, spanning from trainees to mid-career to established physicians, women, those who come from, underserved areas and other countries. So thank you very much, and let's keep the fight going.
It's been a real pleasure to work with both of you professionally. I think both of you have done extraordinary promotion for diversity. You've both worked incredibly hard, and I'm really proud to be able to call you my friends, so thank you.